start it again.
Oh, okay. Previous. There we go.
Thank you. Okay. Hello, everybody. I'm delighted to be here today talking to you about medicines and the environment. And I've entitled my talk, Rethinking First Do No Harm, Healthy Patients and a Healthy Planet. Next slide, please. So today I'm going to tell you why water pollution is so important in the climate change jigsaw, how healthcare actually contributes to this water pollution, the science behind what we've found so far, and so what does that mean for us in our practice? And then I'm going to tell you a little bit about the One Health Breakthrough Partnership and how we're tackling the issue up in Scotland, and finally finish with some top tips about what you can do. Next slide, thanks. So by the end of my talk, I hope that you'll understand a bit more about the environmental impact of medicines right across their life cycle, that you will have sufficient knowledge to raise the profile with other colleagues and friends and family, and that you'll have some take-home tips to help you in your individual practice. Thanks, Alison. So, first do no harm. Excuse me, the Hippocratic Oath. Is it now fit for purpose in the face of impending planetary destruction? A healthy population actually depends on a healthy planet, and there isn't one without the other. So I think it's time to actually rethink that oath. Now, you'll all be familiar with slides like this showing the impact of climate change on human health, talking about disruption to our ecosystems, disruption to our societal system, changing weather patterns, ending up in human health impacts, particularly amongst our most vulnerable populations. Next slide, please, Alison. So, where does healthcare come into climate change? Well, we know that healthcare contributes about 4.5% of global total total net emissions. And if healthcare was a country on its own, it would be the 5th largest emitter. And it's the same as us actually burning 514 coal-fired power stations 24/7. Now, about 25% of the greenhouse gas emissions in healthcare come directly from medicines. And about 60% of that 25% actually comes from the procurement. So the development, the making of the medicine and the transporting it across the world to where we need it. Today, I know on your website you've got lots of information about inhalers and how to green inhaler care already. So today I'm going to focus on the water environment and not the carbon emissions. Next slide, please. So for me, the missing link in all this, well, first of all, last year we saw COP26 in Glasgow. We've seen the IPCC reports predicting global temperature increases, and it seems as if everywhere we turn it's net zero, net zero, net zero. But my question is, what about the ecological crisis? Because biodiversity loss is just as important as net zero. And climate change is just one part of that triple planetary crisis, and it refers to the 3 main interlinked issues that humanity currently faces, and they are climate, biodiversity or nature loss, and pollution. And each of these issues has its own causes and effects, and each issue needs to be resolved if we actually want a viable future on this planet. So today I'm going to focus on pollution and the subsequent loss of nature. And why is this important? Well, One Health is important. Sorry, could we move back a slide, please? Thanks. Natural capital is a big contributor to our society and to our economy, and it's worth approximately £766 billion in the UK. And it contributes to our food and drink production, our leisure activities, and our tourism. And even more now with all the staycations as a result of COVID, of course. So it's really important to protect our nature. Next slide, please. So not only will the loss of biodiversity and ecosystem integrity affect our natural capital, it will also undermine our efforts on 80% of the Sustainable Development Goals. And it'll make it even more difficult to report progress on all the public health priorities of poverty, hunger, health, water, cities, and climate. And we need to look no further than the global pandemic caused by COVID-19, which was a zoonotic disease, transmitted from animals to humans, to know that the finely tuned system of the natural world has been disrupted already. And you'll see in this donut by Kate Raworth, the social and planetary boundaries in the dark green lines, the limits of ecology and society. The safe space within that, the lighter green line, is the safe space for humanity when we are living within the bounds of our ecological ceiling and the bounds of our social foundation. Now, if we start eating into either of those, overshooting the ecological ceiling, we then enter a space where human life is less safe. Injustice starts to occur and our economy degenerates. And I think that, again, the pandemic has taught us that the environment can actually pull the rug out from under us, from our economy, from our society, at any time. So if you look on the top right of the diagram there, today I'm going to focus on how chemical pollution from pharmaceuticals, from medicines, affects our ocean acidification, which links to climate change. Next slide, please. So let's start with some simple maths. And climate change actually is simple maths, because whatever goes into the atmosphere must be removed in terms of carbon emissions. And working on the net zero agenda helps by reducing the carbon emissions by what we put into the atmosphere. But let's remember that what's already in there must be taken out. So we need to take out any carbon dioxide, but we also need to produce oxygen if humans are to breathe. Now, I don't know about you, I could do with 2 deep breaths right now. So let's just stop, pause for a moment and take 2 deep breaths. Okay, next slide, please, Alison. So I hope you enjoyed those breaths, but did you know that the ocean was actually responsible for making much of the oxygen that you just breathed in? Marine plants produce more than 90% of our global oxygen. That's more than our forests and our jungles put together. And plankton actually remove most of our carbon dioxide from the atmosphere. However, our plankton have already been lost, 50% of them, and they are dying at a rate of 1% every year. So our biodiversity is being lost, and it's being blamed on climate change, on carbon dioxide in the atmosphere. However, if you think about it, increased temperatures and more carbon dioxide should actually be feeding nature and resulting in growth. So what we're seeing is actually nature dying, and that is due to pollution by chemicals and the destruction of the ocean. Now, many chemicals are lipophilic. That means that they behave like oils, so they don't dissolve in water. They become absorbed onto microplastic particles, which is another big problem in our oceans and rivers. And these particles are then eaten by planktonic animals or directly absorbed into cells and plants, and that results in their death as well. Next slide, please. So if we thought climate change is bad, then I've got news for you. Ocean acidification is catastrophic. So if we lose the plants that make oxygen and the plankton that actually absorb carbon dioxide, the excess carbon dioxide then dissolves in water, making it less alkaline. And this means that any life that is based on carbonate, which is most of the life in the ocean, will actually just dissolve. And net zero will not halt this. So if we lose the marine ecosystem, we lose our fish, our whales, our seals, but we also start to lose our terrestrial system. So to put it bluntly, if plankton go, humans go. And when the trophic cascade starts, that's the destruction of the ocean, it'll happen really quickly over a period of 2 to 3 years. And the modelling that has been done by the GOES Foundation, from which I've got all the stats for this slide, shows us that this is on course for 2045. So I'll say that again, 2045. That's just over 20 years away. And we cannot stop this by just focusing only on carbon and net zero. We must tackle chemical pollution, and that includes pharmaceutical pollution. But if we do actually affect change, we still have got an opportunity to reverse it. And Sir David Attenborough, in one of his latest ocean programs, has said that plankton are our greatest ally in combating climate change, and they offer a lifeline for humanity. Next slide, please. So where do medicines come into all of this? Well, we know that the prescription of a medicine is now the most common thing that we do in the NHS. We can use them to diagnose, prevent, cure, and treat disease. And every year in the UK, we spend just under £20 billion worth of medicines. But we also know that adherence to medicines is particularly low, and can be as little as 50%, 20% for some inhaler therapies. So if you think of that 20 billion, we're wasting £10 billion in medicines that aren't being used. Next slide, please. But we also know that the use of medicines is increasing. So we've got bigger population, we've got more older people. The older you are, the more medicines you tend to have. We've got technological advances, especially in diseases that were thought incurable previously. We've now got a viral cure for hepatitis C, and for most of our cancers, we can offer 4 or 5 lines of treatment, making cancer more of a chronic disease than it used to be. But sadly, we've also got a pill for every ill culture, where society now turns to healthcare, turns to medicine to fix a problem too often and too quickly, instead of actually taking responsibility and doing something for themselves. Next slide, please. So the medicines that we prescribe, how do they get into the environment? Well, for humans and for animals, every time you take a dose of medicine, between about 30 and 100% of it comes out in your pee and your poo, straight down the toilet and into the wastewater system. And of the human medicines that we find in the environment, about 90% of those are as a direct result of patient use. About 5% comes from people flushing them down the sink or toilet, thinking that's the safest way to dispose of them. And 5% comes from our pharmaceutical production. So why is this a problem if they do end up in the wastewater system? Well, our treatment plants were never designed to remove small, complex chemical molecules. And the removal efficiency of plants can vary between 0 and 100%, depending on the medicine. So inevitably, the water that comes out of the wastewater process, the effluent, can contain small amounts of medicines. And the effluent gets pumped into our rivers and our oceans. The byproduct of the process that you can see the landfill incineration at the bottom right of the diagram there, the byproduct is sludge. And it also contains pharmaceuticals, and we routinely spread that on our crops so that pharmaceuticals then end up entering our food chain. Next slide, please. Next one, please. And the next. So we're now going to have a look at some of the science behind pharmaceuticals in the environment. Next slide, please. Okay, this is a slide from a meta-analysis of research on pharmaceuticals in the environment. It was undertaken by Austerbeck et al., and it shows over 600 medicines or their transformation products have been found in sewage or the water going in or out of the wastewater treatment plants. That's the influent and the effluent, or the sludge. Now, transformation products are actually pharmaceuticals or products that have been created as a result of the wastewater treatment process. So sometimes you can have quite an inert pharmaceutical go into the wastewater treatment plant, but out the other side comes something that's even more toxic. So that's an issue for us as well. And you can see here on the slide that the highest numbers of pharmaceuticals detected, the darker the area, the higher the number, tend to be found in the higher income countries. At the time of this research, there was no data available for the grey areas, but the latest research on the next slide actually progresses this a bit. Next slide, Alison, please. So this research has been undertaken by Wilkeson Boxall et al., and they sampled 258 rivers across 104 countries of the world. So they've now covered every continent. And they analysed their samples for 61 pharmaceuticals, and the concentrations that were found in over a quarter of the rivers were considered to be a threat to either environmental or human health. The drugs that were found in the highest concentrations were analgesics, antibiotics, and anticonvulsants. And interestingly, the authors state that the highest concentrations have actually been found in lower to middle income countries. So they now hypothesize that socioeconomics is involved in pollution. And again, like I mentioned at the beginning, pollution, climate change, etc., is affecting our most vulnerable populations. So this is no different. So these countries actually have access to medicines, unlike the lower income countries, but they may not have as well developed wastewater treatment plants as the higher income countries do. So that's why the medicines are ending up in their rivers. So that's an example of inequalities at play again. Next slide, please. So we've looked at the global dimensions. So let's start to look at the UK. So this slide compares the River Almond in Edinburgh and the Orkney Isles right up at the top of Scotland, comparing and contrasting the different urban and rural populations, the densities of population, the industries that are involved in each of these places. And again, along the bottom there, you can see a range of painkillers, antibiotics, and cancer medicines that were tested for and detected in lochs, rivers, and seawater in both of the places. Next slide, please. Now, this takes us right up to the furthest reaches of Highland in my patch. It's a very small coastal town with just 9,000 inhabitants. But again, you can see that the wastewater effluent, that's the water that has already been treated and is being pumped into the environment, is full of commonly prescribed medicines. So we've got beta blockers, antifungals, antidepressants, anti-inflammatories. Now, I could show you similar pieces of research available for the rivers in York. There's been monitoring done in the rivers Foss and Ouse, and also in the River Thames in London. So it is a global issue, but it's also a UK issue that we need to be aware of and do something about. So next slide, please, Alison. Okay, so we've shown you that it is a global and UK issue. So let's now look at some of the evidence for some of our most commonly prescribed medicines. So starting off at the top there with ethinyl estradiol, used of course in the contraceptive pill and hormone replacement therapy. Ethinyl estradiol can cause feminization of fish, and this happens when the male fish testes actually contain eggs instead of sperm. Now, doesn't take a scientist to tell you that that's not good for reproduction. So eventually this leads to population collapse because reproduction fails. And there are consequences right up and down the food chain. Moving to the middle section, fluoxetine. It's been shown to delay tadpole development. And then our common antibiotics at the bottom, they inhibit growth in duckweed. So again, thinking about that whole end-to-end food chain, it's really important that every component of the food chain exists and isn't impacted by pharmaceuticals. Next slide, please. And can you press it twice more, Alison, please? Thank you very much. So I'm focusing in on ethinyl estradiol here. It's one of our endocrine disruptors as well. You can see the letters there, PNEC, P-N-E-C. That stands for predicted no effect concentration. And this is the level or the concentration below which a medicine is thought not to have an environmental impact. So anything above that, i.e. the light and dark orange and the rust colours, is showing you that ethinyl estradiol is having an impact on aquatic life around the world. Now, if you look at the table on the right-hand side, you can see a range of values that are all above the PNEC. The PNEC, the maximum PNEC there, is sitting at 0.001 micrograms per litre. And if we look at somewhere like Brazil, it's almost 6,000 micrograms per litre. And that's most likely, again, because they have got underdeveloped wastewater treatment plants in that country. Next slide, please, Alison. Right, I just have to get my screen back because I'm not pressing any buttons. It's gone to sleep. So I'm now going to look at three of our most commonly prescribed painkillers. So let's start with paracetamol. It is one of the most commonly prescribed drugs right around the world, and it's also been found in waters across the globe. And it's even been found to survive in drinking waters in some locations. It's been labelled a priority drug, and it's considered to have significant ecological hazard potential. It can also amplify the toxicity of other drugs, so that complicates the environmental picture. And it degrades in light, and after degradation, certain photolysis products may actually be more toxic than the original paracetamol itself. And again, this further complicates our understanding of its overall impact. It has been found to be acutely toxic to nearly all species of aquatic life, but it's specifically neurotoxic to freshwater shrimp and planarians, even at low doses. And these animals are important because they are crucial elements in our food chain again, but they're also filter feeders, so they tend to accumulate higher levels of environmental pollutants. Next slide, please. So moving on to the toxicity of ibuprofen, this research was done in the zebrafish that you can see here. And again, we can see impacts on reproduction, cardiac function, and ion transportation. Not good to keep the fish alive. Next slide, please. Now, this research was done looking at chronic exposure of rainbow trout to diclofenac, and the chronic exposure is over a period of just 28 days. And again, here you can see the results are various ultrastructural physiological changes across a range of organs, from changes in metabolism to glycogen stores, kidney failure, and finally necrosis of the gills. So if the gills die, the fish die. Next slide, please. So I've just given you a few examples to show you the evidence of environmental harm from the medicines that we commonly use. And we've seen evidence for behavioural, physiological and reproductive changes across the aquatic environment. But many of the recent studies are actually raising health concerns in susceptible human populations as well. For example, infants, the very ill, pregnant women and immunocompromised patients. But one of the major concerns from environmental pharmaceuticals is the acceleration of antimicrobial resistance, or AMR. Next slide, please. And I thought I'd focus in on this for a moment because it is such a significant public health concern. And again, it's a global public health concern. It's often referred to in papers as a silent pandemic, but I like to refer to it as pandemic plus, because I think it really brings home the magnitude of the impact it's going to have on our population. So over the last couple of years of pandemic, we've seen between 5 and 6 million deaths globally. But by 2050, it's estimated that AMR resistant infections will become the leading cause of death in humans. And estimates of modelling are saying it's 10 million people every year worldwide that will die. Now, of course, we know that every part of our health system depends on antibiotics, whether that's to treat or prevent infections. 1 in 3 people that goes into hospital gets an antibiotic, and 90% of the overall antibiotic prescribing occurs in primary care. So try to imagine life without antibiotics. In surgery, one often gets an antibiotic before or during the operation, but we are running out of antibiotics that are not resistant. So this means that we may not have any to use in future when we need them. And that means that routine operations like C-sections or hip replacements will become much more dangerous, and they might not be able to be carried out at all because they could become life-threatening. If they are carried out, it could mean much prolonged hospital stays for patients. And the resilience of the health service, the demand increases that we're seeing, we will not be able to cope with that either. So the pipeline of new antibiotics is near to empty, so it's really vital that we keep the ones that we have working, and that means preventing the development of further AMR. So we really have to tackle that health protection and environmental pollution together. Next slide, please. So the evidence so far, what's it telling us? Well, medicines are made to have a biological effect at really tiny amounts. And they are indeed having that biological effect when they leave the target organism, which is a human in this case, and when they go into the aquatic life. So they're having the same effect that they do in humans. They are toxic, they are causing harm, and they are accumulating in our crops. We've seen research looking at lettuce, potatoes, soya, carrots, all have been found to have pharmaceuticals in them. Excuse me. And they are persistent, so they stay in water for a long time. And some pharmaceuticals which aren't very persistent, like paracetamol, it degrades quite quickly, but we use so much of it and it enters our water so often that it has what we call pseudo-persistence. So it's in the water all the time, basically. We know that we can't remove them very well. It's really difficult to remove them. And it would cost almost £8 billion in the UK to upgrade technology, which would also have a huge carbon emission for the wastewater industry. And it wasn't until 2006 that environmental risk assessment actually became part of the licensing from medicines. So we know that the vast majority of the medicines we use were made before 2006. So we don't know what they do to the environment. We don't yet have the full evidence for them. So next slide, please. So it's a really wicked problem. Nobody, no one organisation, no one country can actually solve pharmaceutical pollution on its own. We do need an integrated, collaborative approach, and we need leadership and partnerships to help tackle it. Next slide, please. And this is exactly what we have done in Scotland and kicked off in the Highlands. We formed the One Health Breakthrough Partnership. It's a unique collaboration between Scottish Water, the Scottish Environment Protection Agency, SEPA, and the Environmental Research Institute of the University of the Highlands and Islands, along with NHS Highland. We have a lot of water in the Highlands and Scotland. Alice and I were just talking about it at the beginning. It's rained so much this week. And we want to keep that water because, as I said earlier, it's our food and drink production, it's our tourism, it's life, basically. So the vision of the partnership is to have a one health, non-toxic environment. And we aim to actually improve both healthcare and the environment. We're conducting research and we're informing policy and driving forward innovation. And for the last few years, we've been focused on pharmaceuticals and the environment. Next slide, please. Now, this OECD diagram nicely shows the life cycle of a pharmaceutical from its development right through to it ending up in the wastewater treatment plant in the pink on the right-hand side. And if we actually consider a medicine like this, we can see that there are many points at which one can make an intervention for the better. So in the partnership, we're taking an upstream public health approach, basically trying to reduce the overall prescription of medicines, offering alternatives such as blue-green prescribing using our natural resources, educating the public about correct disposal, and investigating some at-source removal technologies for our hospitals so that we can prevent the more toxic waste from our hospitals entering the municipal wastewater treatment system. So let's have a look at some of the work that we're doing now. Next slide, Alison, please. So one of the first projects that we did was to become better water stewards in NHS Highland. And essentially, being a steward is taking care of something you don't own. So water stewardship, antimicrobial stewardship, for instance. And we have been successful in being the first hospital in the world to be accredited with the Alliance for Water Stewardship standard. And it's really a bit like a fair trade standard, but for water use. So we use a lot of water in the NHS, and we have a real social responsibility to make sure that we are all good water stewards. Can you imagine the pandemic without water when we were all washing our hands so often to prevent the spread of disease? And obviously, you know, we need that in everyday life. The project as a whole, it really required us to engage with our stakeholders, had to show great leadership across the whole system, which now has a much better understanding of the water cycle and the 5 components that are involved in the standard. As part of this project, we actually tested the water coming into our hospital from Loch Calder. We tested the water coming out of the hospital and also the water coming in and out of the wastewater treatment plant in Caithness. We were looking for 8 pharmaceuticals and we detected 7 of them. And the highest concentrations, as you would expect, painkillers, paracetamol, antibiotics, and antidepressants. Now, this work actually sparked off another couple of projects. Next slide, please. So we now have a PhD student, a hydronation PhD student, Manuel, who's looking at the use of nanotechnology to prevent hospital medicines from reaching the sewage system. And he's aiming to show that photocatalysis can oxidize the medicines that you see at the bottom left and ensure that the water that goes out is a lot cleaner than it is at the moment. Next slide, please. Another piece of research that we ended up commissioning was this CREW research. CREW is the Scotland's Centre of Expertise for Water. And we we gathered all the research that had been done on pharmaceuticals in Scottish waters between 2014 and 19. We managed to gather data on 16 medicines, so that's given us a really good picture of what was detected where and in at what concentrations around Scotland. But it's also shown us some gaps in terms of the compounds found and also the matrices, the water matrices that were analysed. So that could be lochs, rivers, coastal waters, etc. Out of the research, we've actually identified 9 medicines that we have prioritised as posing an environmental risk. But we now also have a database with us, over 3,000 data points in it. And this is a first in the UK and I think worldwide as well. The research, along with the database, has been recently published. It's at the web link in blue there. So please do go in and take a look at it if you are interested. Next slide, please. Now, we've used the CREW research, that database of 3,000 data points, to actually populate SEPA's Spotfire tool. And it's a GIS mapping resource, so it's a geographical information system. So it's essentially a database that you can plug data into and it can show you on a map what's going on. But the novel thing that we've done here is that we've also populated it with national prescribing data from Public Health Scotland. And this slide shows the front screen of the tool. We are awaiting its imminent publication. I just heard at 6 o'clock tonight that we're going to publish it the week commencing the 13th of June. So do look out for it. I will be tweeting it when it comes. So I'd love you to have a look at what it can do because it's the first time again in the UK and the first time I think in the world that this has been done, combining water data with prescribing data. Next slide, please. Now, these screens are probably quite hard for you to see, and quite intense for a quick look, but I hope to give you some idea of the art of the possible here. If you look down the left-hand side of the slide, that's difficult with my teeth in, you can see that you can filter by various things. So the first filter at the top is by the water matrix. So is it the influent, the effluent, a drainage operational area, etc. And then you can move down to therapeutic group. Is it an antibiotic, an antidepressant? And if you want to choose a group, you can also then hone in on a particular pharmaceutical. And for the purpose of this slide and the next, I've used clarithromycin because clarithromycin is one of the pharmaceuticals that is under monitoring across every water company in the UK. It's part of what they call their SIP programme, their chemical investigation programme. And then below that, you can actually then filter by health board as well. You can look at the whole of Scotland or an individual health board. And after that, you can drill down into GP practice. So if you look at the graph on the right-hand side here, again, it's clarithromycin. So the dotted line going across is the PNEC. And remember, that was the predicted no effect concentration. So any of the little triangles that you see above that line are actually in concentrations above the PNEC and could be having an environmental impact. Next slide, please. Now, this slide, I've actually drilled down into 3 GP practices, which are near a sampling point from Scottish Water. On the map on the left-hand side, you can see that anything that's coloured red, the triangle there, again, we've got an exceedance of the PNEC, and the orange dots are all the GP practices. So we're hoping to use this tool to see whether there's a correlation between what's being found in the environment and what's being prescribed in the locality. So if any of you are into prescribing data, I'd love to work with you on the art of the possible on this. Next slide, please. So moving on to blue space interventions now. Part of the vision of our partnership is that non-toxic environment, and how better to achieve that and reduce patient harm from medicine than by social prescribing. Now, you're probably all very familiar with green prescribing, getting people out into our green spaces to benefit their health. But now we have another PhD student, Jules, who's looking at blue space interventions, particularly around mental health. And he hopes to develop a blue prescribing strategy for Scotland. He's currently in the second year of his PhD. Next slide, please. And as part of his work, Jules has looked at the gaps and barriers to eco-directed prescribing in Scotland. And this is as valid for the whole of the UK as it is for Scotland. And again, this policy review has been recently published, and I've referenced it in my last slide for you. So it's no surprise, what he's come up with, because prescribers actually need operational guidelines and strategies to tell them how to prescribe in a greener fashion. Decision tools aren't available, data aren't available. There isn't any national body coordinating greener prescribing, and most stakeholders don't know much about what I'm talking about tonight, so they don't know that they can or should be making their prescribing any greener. So please do take a look at that. It's a really interesting policy edit. Next slide, please. Now, because AMR is such a public health concern, 2.5 years ago, we actually developed a video, a consumer information video on antibiotics and AMR. And we launched it back in 2019 on World Antibiotic Awareness Day in November. And within a month, we'd had over 130,000 views of it. And we aimed to improve people's knowledge of how antibiotics work, when they do need one and when they don't. Understanding of AMR and about AMR in the environment as well. That they should take all their antibiotics and not just stop after 2 days when they start to feel better, and how they should dispose of them. Next slide, please. And we carried out an evaluation, and this is just one facet of the evaluation. It's the educational impact. And you can see here that we've made good gains in educational impact. People are more aware that AMR is a problem, that AMR in the environment is an issue. 100% of people, both of those now saying they've learnt that. Also, almost everybody will now finish their course of antibiotics, because they understand that it can lead to more resistance. And we've reduced the number of people who would share their antibiotics with others. Now, this video is on YouTube and it's free for anyone to use. So if you want to do an antimicrobial campaign, please feel free to share it. And it's in my references at the end as well. Next slide, please. Now, the partnership's been going for about 4 years, and recently we've taken part in a One Planet Choices trial to support our future planning and activities. And this is a decision-making methodology for several organisations, where no one single organisation controls all the elements of a complex system. And it involved us being really clear about the decision that we wanted to make, that we were looking at human pharmaceuticals and the environment. We looked at current and future drivers. How is climate change going to affect pharmaceuticals and the environment with less rainfall, hotter summers, etc.? So we considered various options and scenarios of things that we could do. We appraised them all, and then we chose the best path according to certain criteria about where we want to go. Next slide, please. A couple of more presses, please, Alison. That's it, thank you. So this slide shows our 3 broad areas of focus: campaigning, practical interventions and pilots, and research. Now, of course, our work covers all of those at the moment, but if we wanted to get the biggest bang for our buck, then we prioritised section C, the orange one, which is practical interventions and pilots. And you can see here that all of the interventions across this whole slide are upstream ones. So again, just trying to prevent pharmaceuticals from getting into the environment in the first place, rather than trying to deal with the problem once we're faced with it. Next slide, please. So pulling together everything that I've told you so far, and what we're going to focus on next. So what do we already know? Well, pharmaceuticals are expensive and very hard to get out of wastewater, and actually the wastewater process can make the issue worse. They are highly bioactive, they are having effects, and we are now left with this chemical cocktail, not just pharmaceuticals, but microplastics, heavy metals, and other chemicals that are in our rivers and oceans as well. And we don't know how that chemical cocktail actually behaves. We know we are suffering from biodiversity loss. We are speeding up that ocean acidification, and we are having unnecessary animal and fish suffering, and it looks like potential human suffering coming soon as well. Next slide, please. But I think it's actually even more important what we don't know yet. So we don't know whether daily exposure to subtherapeutic doses over a period of time will have negative human health impacts. In various areas of the world, pharmaceuticals are actually contained in drinking water. And I've said already that they're in our food chain. We don't know how that mixture, how that chemical cocktail is going to interact. And of course, we haven't got those data on just how toxic, persistent, or bioaccumulative all of our medicines actually are. Next slide, please. Now, I just want to turn to the pandemic for a moment, and I'm sure we've all heard enough about the pandemic, but I think it's actually demonstrated that anything is possible as an NHS, as a society, as a global community. We can collaborate in a crisis when the heat is on. And within the last 2 years, there have been strides made in the identification of coronavirus, in the treatment, social policy, PPE, testing, wastewater, epidemiology. And we've just undertaken the biggest, and still are, the biggest mass vaccination campaign ever undertaken. So I believe that this type of collaboration, when the heat is on, stands us in good stead to actually tackle the triple planetary crisis. Because believe me, the heat is most definitely on right now for the end of human life as we know it, if we keep on the same trajectory. So we've found that the One Health Breakthrough Partnership has been so useful for collaboration, for sharing data, for learning from other agencies, and just piecing those bits of the jigsaw together. Next slide, please. So what's next? Well, we haven't got all the evidence yet, but we can't wait, because ocean acidification is 20 odd years away. But we have got enough to be working with, and we need to start taking a pragmatic cross-sector and integrated approach to all of this. Our goal is to use pharmaceuticals only when they're absolutely required, and when the patient wants them if they are required, and to actually apply those principles that are so clearly laid out in strategies such as realistic medicine and prudent healthcare, to really think about the risks and benefits of medicines and what really matters to the patient, because quite often it's not actually getting a medicine. And just to always remember that what's good for the planet is also good for patients and the public, and that healthy people are low carbon people and low pollution people. Next slide, please. So it's over to you now to think about your pharmaceutical footprint. So let me ask you what you think about your pharmaceutical footprint. So what size is it? How much are you prescribing? Are the medicines you're prescribing absolutely necessary? And what are the challenges that you come up against to actually not prescribe a medicine? Do you always go to the lowest effective dose? Can you use blue-green alternatives, even as a trial for a patient? Could you implement a deferred prescription? So if, say, for instance, if you get a patient with depression, could you offer them online CBT for 6 weeks? Because we know that antidepressants take 6 to 8 weeks to act. And we know that CBT is just as effective as antidepressants in mild to moderate depression. And are there medicines that haven't been reviewed for a while or aren't being used? Remember that concordance compliance figure, adherence was 50%. And are you seeing the expected outcomes that you wanted to from the medicine that you're prescribing? Next slide, please. So I've quickly mentioned already the various reports, such as the Chief Medical Officer report in Scotland, Realistic Medicine, Prudent Healthcare in NHS Wales, and also Choosing Wisely from the Academy of Royal Medical Colleges. So what action, if any, should we as clinicians take? Well, I think the most important thing to remember, especially in this increased demand, low resilience health system that we find ourselves in post-COVID, is that we should ensure that any healthcare we provide focuses on the true value to the patient. Because waste in healthcare should be assessed not only in terms of what we might throw away, but also interventions that don't add value for patients or that actually cause harm for patients. Because that 11% of hospital admissions as a result of adverse events from a medicine, much better could we cope in hospitals if we didn't have any of those adverse events, bed blocking? Next slide, please. And the Academy of Medical Royal Colleges has come up with this acronym, BRAN. It's always useful to think about, and I'm sure most of you do this in your everyday practice, but just good to highlight it again. So what are the benefits of the medicine or the intervention that you're thinking of giving the patient? What are the risks? Do the risks outweigh the benefits? Are there any alternatives? And actually, what if we do nothing? So applying BRAN actually helps you to potentially wear a smaller shoe size for your pharmaceutical footprint. Next slide, please. So I would ask you that at every stage of your prescribing that you stop and think, what are the patient's desired outcomes, and does the patient actually want an intervention or the intervention that you're offering? And to use that BRAN acronym. Doug Danforth in his BMA paper has said that starting medication is like the bliss of marriage and stopping them is like the agony of divorce. And I think we can all confer with that. So think before you prescribe, because it's hard to stop it. Think whilst you prescribe. So think again about that deferred prescription, the minimum dose, and the amount that you give somebody the first time you give them a medicine. Not the 28-day supply, but maybe less than that. And plan a review in if it is a new medicine for them. And then after you prescribe, obviously, thinking about the monitoring and the reviewing and asking the patient if they've got any challenges with their medicines and how they're getting on with taking them. Next slide, please. So this slide always bores me, and this is the returned medicine from a deceased patient, just one patient. And I ask myself, how did that patient get to the point where they have 20 salbutamol inhalers there, where they have close on 20 packets of diuretics and goodness knows what else on that table? So again, think about your repeat prescribing systems. Is there anything that you can do to highlight over ordering or non-adherence? Next slide, please. So I think for us in healthcare, if we're really to prevent pharmaceutical pollution, if we're really to keep the healthcare system resilient, we need to think about health as a river of life. And we really want to keep our patients up the top in the nice, calm, flowing water where we could canoe quite nicely without actually heading over that waterfall into disease and ultimately death. Next slide, please. My boss has just come home from holiday and he sent me this photograph yesterday, which was just really timely. And I think it says it all really, that nature is the largest pharmacy in the world. And actually, if nature was our largest pharmacy, I wouldn't be here talking to you about pharmaceutical pollution of our environment. Next slide, please. Could you just go back one, Alison? Thank you so much. So healthcare has made great strides since, especially since the NHS evolved. And the life expectancy of a child born today is actually 100. But how do we balance that up with what you've just heard tonight from me, that ocean acidification, that climate change, actually, there's probably not 100 years left in this world. So what can you do in your practice and in your daily life to ensure that a child that's born today actually lives to 100 in a planet that has got nature and clean water? Next slide, thanks. So I hope you've learned lots tonight, that you've taken away some tips, and I want to ask you to go and make Hippocrates proud and actually first do no harm, make it fit for purpose for the healthcare system and the world that we live in the century that we're in. Next slide, please. So I'd like to finish with a quote from Sir David Attenborough, who has been absolutely instrumental in educating the masses about our natural world. And he said, "The truth is, the natural world is changing, and we are totally dependent on that world. It provides our food, our water, and our air. It is the most precious thing that we have, and we need to defend it." So let's try and defend it all together. Thank you so much. Next slide, please, Alison. So there you can see, if you would like some more CPD from tonight, there's a whole list of all the references that I've used. So please do look them up. Thank you very much.
Thank you, Sharon. That was amazing. I'm just going to stop sharing. And if anybody, which I'm sure my mind is still reeling about plankton, I'm sure people have lots of questions. If they could pop them in the chat, that'd be grand. So sorry, every time I clicked on anything, the slide jumped, so I wasn't monitoring the chat as we went along. So 2 secs.
Well, yeah, let's see. There's a question from Katrina there. Please, Katrina, please do, everybody. She's saying, what do I think is the most effective way of urgently getting my messages out to every prescriber in the country? I've been talking like this for 4 years now, and I've talked to probably about 3,500 prescribers across the UK so far, but there are still more, I'm sure. So absolutely happy if people want to use my slides to create a shorter presentation for your own clusters, for your own practices, please do. Some of the slides are subject to data sharing agreements, so if you want to, just drop me a line. Got my email address or my Twitter handle there. Drop me a line and I'll tell you which ones I have to ask my partners for authorization in.
And I think Honey was asking if you would write a wee section for the Greener Practice website.
Yeah, sure, I'd be delighted to, Honey, if you think it's helpful.
Can we access this tape presentation? So yes, that Hannah is very kindly recording this, and we're going to upload it onto the Greener Practice website. Can I ask a question about prescribing specifically? So obviously you showed the slide about the ethinyl estradiol, and we're under quite a lot of pressure at the moment about HRT after Davina McCall's programme on Channel 4, and people wanting HRT in their mid-30s because they forgot something, and you know, it's quite difficult. And I was just wondering, so obviously HRT is a lower concentration of estrogen, but is that likely to have an impact?
I believe that it is, because it's the combination of everything that comes out of the wastewater treatment plants. Okay. So it will do. I think that different formulations may be better than others, but of course anything that you put on your skin as well gets washed off in the shower and goes straight down. So things like the estrogen gels or diclofenac gels, Voltarol, Emugel, etc., they will all go straight down into the wastewater system as well. I would say I'm not a menopause expert, apart from personal experience, Alison. So
me too.
So I would have to look at the formulations which would be better. We have had discussions in Highland with our sexual health consultants about using coils more often for menopausal women. That's slightly better.
Okay.
But obviously there's a big capacity issue in secondary care there as well.
Yeah. So Honey's asking what happens to pharmaceuticals in natural water purification systems, for example, reed beds.
Reed beds. Now, the Environmental Research Institute is actually using reed beds as a natural technology to try and remove pharmaceuticals. So they're still undertaking that research. So I could find out for you, Honey, and maybe get one of them to write something for you as well.
Sorry, and Hannah's asking if this is being discussed at a government level.
Okay, in Scotland, certainly it is. I've been working with the Scottish Government on their climate change strategy. And as I said at the beginning, my frustration is the net zero agenda, that's all anyone ever thinks about. And when our climate change strategy was being developed, it was all about estates, the use of electric vehicles, the use of better heating systems, reducing our electric needs, etc. But we know that 80% of carbon emissions come from clinical pathways. So I've managed to get a lot of clinical pathways into the Scottish strategy, and also pharmaceuticals in the environment and water stewardship. We're just waiting on the final strategy in Scotland to be published, probably in mid-June. The comments are all in for perusal right now. But what we have got is the policy for health boards, and water stewardship is now mandatory for all health boards across Scotland. So I expect to see health boards in Scotland waking up to the issue that there is an issue with pharmaceuticals, and hoping that I can share the work that we've done in the One Health Breakthrough Partnership more widely. In England, you have the Greener NHS there. It's largely focused on net zero carbon emissions. I believe there have been some discussion with Nick Watts, the lead for Greener NHS, about this issue, and he certainly knows about our work. So there is some work going on with NICE, looking at incorporating environmental risk into health technology decision making. So that's a pilot project that's going on at the minute. And I'm certainly in discussion with lots of different areas, researchers and colleagues in England about this. So hopefully Greener NHS will wake up to that very, very soon.
Do you think the guidance will ever change about patients, once a medicine's been dispensed, and the minute it's given to the patient, even if they then walk out the shop and come straight back in and say, this is wrong, or I'm off this now, it then has to all be destroyed? Do you think that'll ever?
Yeah, well, I certainly hope so. It's been complicated recently by a new directive called the Falsified Medicines Directive, so that every medicine, when it's manufactured now, has a barcode on it, and that barcode is zapped at various times across its life, when it goes to the wholesalers, when the wholesaler delivers it to the pharmacy, and when the pharmacist dispenses it to a patient. So certainly when I go in for my prescription medicine now, before they hand it over to me, they have to zap a barcode to show that the medicine has left the pharmacy. And that new directive came about because of the risk of falsified medicines across the globe. It was becoming big business to actually falsify medicines. So that actually gives us security that the medicines we're prescribing are actually valid medicines made by a pharmaceutical company. But what I hope we could move to, it's just come in a couple of years ago, but what I hope we could move to is a situation where we have sensors on packs, because much of the issue at the moment, apart from the barcode issue, is that we don't know in what conditions a patient has kept their medicine. Many patients keep them in their bathroom cupboards or their kitchen cupboard next to the cooker, and they're both hot and steamy atmospheres, so that can affect the medicine inside the blister pack. So I hope that we can get sensors on medicines that show us how a medicine has been stored and whether it's gone above the desired humidity levels, etc., and that we can start to reuse them. There's been work done, I think it's Reading University, looking at the reuse of medicines, and about 80% of the population said yes, that they would be okay in receiving a medicine that had previously been dispensed. So that's heartening to think that the population actually wants to reduce waste. So yeah, I think a lot of research going on at the minute, and I hope that the wastage that we see will entice government to actually reverse or help change that directive in some way.
Okay, so we've got, do you think a lot of preventative medicines will cease to be used, and can green-blue prescribing prevent the need for them? Do we need more accessible info, rate benefits and risks built into our system so we can discuss them more easily?
Yes, so something that I don't think prescribers or patients know enough about or have enough tools at their disposal is number needed to treat and number needed to harm, and just helping you weigh up the risks and benefits of a medicine and how many patients you have to give it to actually get the result that you want. So, yep, some of the polypharmacy guidance, I think, in the UK has got nice diagrams that display NNTs and NNHs quite nicely, but I think we do need the public to understand much more that a medicine may not actually be the answer for them. Do I think that preventative medicines will cease to be used? That's a difficult one. Yeah, it's very difficult. There is a case to say that, yeah, that might happen, but I think we also need to know a lot more evidence about green and blue prescribing. We do have a lot of evidence. Social prescribing's been around for more than 20 years now. It's just not consistent across the UK yet, and it's not accessible for everybody. So there is a lot of evidence out there about the benefits that come, in terms of mental health, physical health. I think NICE has recently put something out about rheumatism and not to use painkillers because of the rebound effects, for instance, of paracetamol. But actually to get out there and exercise, to walk every day. And of course, Jules is looking at mental health. There's a lot of evidence around mental health. So maybe it's a good thing that preventative medicines have stopped, because actually people can do a lot for themselves through healthy diet, exercise, mindfulness, etc. We need to watch this space, I think.
And Honey was saying they've had a conversation about taking used HRT patches back to pharmacists for incineration.
Yep.
So,
no, that's absolutely. It's the same with HRT patches or morphine patches. When you remove them, you should fold them in half so that any drug that's left in the patch can't leak out into the environment. They shouldn't be popped in the bin, because they will go to landfill and they will come into contact with something that's sharp, and the medicine can then leak out into the soil. So yeah, absolutely, all medicines that people have should be taken back to their pharmacist for disposal. I did have a conversation on another WhatsApp group I'm on today about the disposal of inhalers, actually. And most people actually just chuck their inhaler in the bin. And again, especially if it's an MDI with a propellant gas in it, that propellant gas can leak out of the canister and go straight up into the atmosphere and hang around for 1,300 years, as we know that they do. So again, I think the message may be out there to take medicines back, but maybe some people don't think of inhalers as medicines. They think of things that come in blister packs as medicines. So that's just a point to remember, that if you have got patients, do remind them to pop their inhalers back to their community pharmacy as well.
I think something we've started doing on our inhalers, you can set in vision, you can set certain medicines to pre-populate text. So it says, please return your inhaler to your pharmacist on all our inhalers. But we could do that for all our patches, actually.
Mm-hmm.
So the clinician doesn't need to necessarily go through it all, and it would flag it up to you to remind you to say to the patient, and it would just automatically print off.
That's a great idea, yeah.
Anybody got any other questions or anything they'd like to say?
Yes, I've picked up a question there in the chat. Alison, how can we encourage our local pharmacies to take unused medications back and to raise the profile of this? Certainly in Scotland, for the pandemic, medicine taking back was stopped, was halted during the pandemic, mainly to stop contact between patients and the pharmacy staff. It is back to normal now, but it has been complicated by a huge fire and some contractual issues at the waste incineration site. So we still have pharmacies across Scotland, and I think across the UK as well, saying that they haven't got the space to keep the big yellow drums that they dispose of them into for incineration. I hope to work with Community Pharmacy Scotland very soon to get this message out to community pharmacies as well as out to all the prescribers that I usually talk to. So I hope that helps. If you can't get them to take it back, they are under contract to take medicines back. And if they say that they haven't got the space or they haven't got space left in their yellow bins, I think, you know, a few tweets, a few letters to the Health Board Estates Department to show that this actually is a problem would be very helpful, because we do need to take wasted medication back so that it doesn't harm the environment and also doesn't harm our patients or their children. Yes, Mike, you're absolutely right. I've just seen your comment there. There is a legal responsibility. And I think in Scotland as well, GP practices can also receive medication back. I don't know about the contract in England, but that is the case in Scotland. You probably don't get much of it back, but again, it is in the contract, I believe.
Yeah, we've just recently been provided with the bins actually to send it back.
Yeah, Katrina's asking if there's been any work done to compare NNTs for medicines with green and blue space. I was actually at the Faculty of Public Health conference in Scotland last week, and I joined an environmental economics workshop, and that was my suggestion to them, that we actually do need NNTs and NNHs. Don't think there is that much NNH for green and blue space interventions, unless you fall off your paddleboard and drown. But no, seriously, it would be really good if we could have some measure of how effective they are, and an easy one.
Anybody else? So Honey's saying quite rightly, we probably need greener NHS to take a lead on medicines.
Yes, they have recently employed a lead for medicine sustainability. I think that they're probably going to be busy with inhalers and inhalational gases to start with, because they make up together 4 or 5% of the greenhouse gas emissions. But yeah, hopefully we can get NHS England on board and NHS Wales.
I think I saw in a chat somewhere that somebody was going to look at my bugbear of emollients.
Yes, Alison, I'm thankful that you've raised that, because we emailed about that a few months back, and I had contacted my Meds Info department to get us some information on which emollients actually don't contain palm oil or crude oil derivatives. And I've just had an email back to say that they still are overcome by COVID queries. So I'm going to look somewhere else, maybe at some UK MI groups, to see if we can get that, because I think that would be really helpful as well. Because again, people don't realise that a lot of the time that there are palm oil or crude oil included in almost all of the emollients.
Thank you.
That saves me an email to you.
Somebody's asking if anaesthetic gas metabolites get into the ocean.
Yes, indeed they do. Yep. I've recently also presented to the Association of Anaesthetists, and things like propofol, that their new Tiva drug actually gets into the environment and can cause damage, and other local anaesthetics like lidocaine actually do cause environmental damage as well. If you're interested, if you go to SEEG, which is the Scottish Environment Anaesthetics Group, SEAG. I've done a couple of articles for their newsletter, and you can find out more there as well. So even though they're getting rid of desflurane, there's also the environmental impact of the other medicines that they use, the water impacts, I should say.
Wow. Okay, I can't thank you enough. It's such an amazing, thought-provoking talk, and you're so knowledgeable and so calm as you tell us all this really worrying news.
Well, I hope that the technical glitches at the beginning didn't detract from your enjoyment of it all. It is scary information, and sometimes it's a bit of doom and gloom, but you know, there is the window to turn things around, and we do have to tackle the net zero, but pollution, we also do have to sort that out as well. And obviously we don't want to stop people having medicines when they need them. That's not the point. But you know, a recent Chief Pharmaceutical Officer report in NHS England shows us that at least 10% of prescribing is overprescribing. And I know that as prescribers, you're up against challenges, if not time challenges, patient pressure, expectations, etc. So it's how we all work together and create the time for you to have that conversation with your patient about this, because it all does take time.
Okay, thank you so much, Sharon.
Thank you, everybody, for listening.
And we'll get it. Hannah will post it on the website because she's much cleverer than I am. Thank you, Hannah.